I'm Julie Pace, Washington Bureau Chief for the Associated Press, and this is Ground Game. The coronavirus pandemic ranks among one of the most consequential stories ever covered by the Associated Press in its 170-year history. Here to take you inside the outbreak is AP's Ralph Russo.
From the Associated Press, this is Inside the Outbreak. I'm Ralph Russo. Today is Monday, April 27th. A thinner-looking British Prime Minister, Boris Johnson, is returning to work after a bout with the coronavirus and with a strong warning against easing the country's lockdown. Meanwhile, a piecemeal lifting of restrictions is happening all over the world. According to Johns Hopkins University, the COVID-19 death toll worldwide is more than 207,000. Here in the US, the number of people killed by the virus is more than 55,000, almost all of those coming in less than a 2-month period. Today, we will get a view front lines of the pandemic. Our guest is Dr. Daniela Lamas, who is a pulmonary and critical care doctor at Brigham and Women's Hospital in Boston. Dr. Lamas has written extensively about critical care, including a book about the patients who survive critical illness because of the advancements in treatment and technology and the cost that comes with. The book is called You Can Stop Humming Now, A Doctor's Stories of Life, Death, and in Between. Dr. Lamas will take us inside the intensive care unit. She paints a detailed picture of how COVID-19 patients are treated, how they die, and how they recover. We'll talk about the toll the pandemic is taking on the families of those lost, and we'll discuss how even doctors and healthcare workers who routinely deal with death as part of their jobs are being challenged as never before. Welcome to the podcast, Dr. Daniela Lamas. Thank you very much for taking some time to be with us, and thank you and all your colleagues for your vital work during this crisis. First of all, doctor, can you explain to our listeners what kind of illnesses a critical care doctor usually treats?
Sure. So usually a doctor in the intensive care unit, in the medical intensive care unit, which is where I work and which is where many of the COVID patients are cared for, treat respiratory failure from various causes, from pneumonias, bacterial or viral, sepsis from other infections, and reasons for shock for people to be sick enough so that they need medications to act directly on their heart to raise their blood pressure. So a variety of diseases, heart failure, strokes, heart attacks. People in neuro ICUs deal with neurologic catastrophes. Surgical ICUs deal with trauma. So a real breadth.
You've been writing a lot recently about your time in the ICU, including about one of your patients dying alone in the hospital. Needless to say, that sounds extremely difficult. What is it like to deliver end-of-life news over the phone? What is missed without face-to-face interaction and the possibility of human contact?
I've been thinking a lot about the sort of isolation and end of life and isolation that is occurring as a result of coronavirus. And to set the scene a little bit, we are so used to having families in the intensive care unit. We have involved families to the extent that we have them present on rounds for their loved one. And we even sometimes have families in the room during the setting if there is a cardiac arrest and we're doing resuscitation attempts. I've had families there in the corner watching. And it's horrifying to be sure, but when it is over, they do know that we have done everything possible for their loved one. And now, in stark contrast, I don't even meet these people. I talk to a family member over the telephone, sometimes late at night, and I have to try in some way to convey with my voice and the words that I choose without eye contact, without body language. I have to try to convey the fact that we have tried everything, that we have tried hard, that we've worked for their loved one, but that it's not going to be okay. And it's just an entirely different and very surreal, really, dynamic. that feels isolating, colder. You wonder at the other end of the line, you can't see the person. What are they thinking? How are they feeling? And how can they place this sort of blind faith in us? I'm often amazed as a physician in the trust that people place in us. It's an awesome responsibility. And it feels even kind of more of a weight when this person on the other end of the line can't even see you. They can't even see the fact that you treated their loved one with grace and dignity and care. So it's really challenging. It's really challenging. And I wonder, as we think in many ways about how to reopen things when the world will become more regular again, I wonder when we should start thinking about shifting that balance of safety, but also this huge tragedy of isolated deaths.
Let me ask you, doctor, about a little bit of a follow-up on that. As you have done these type of conversations with people who have lost loved ones, is there any way that you've been able to learn better ways to do it? Have you talked to other doctors about, "Hey, listen, are there bits of information we can share that that give a little more comfort to these people who have lost loved ones?"
Yeah, I think over time we become better at everything we do, even if it's an odd and entirely kind of not human way of sort of allowing a solitary death and delivering news over the phone. And I think one way that does help, and something that we've learned from other colleagues and that we've kind of worked on together in the hospital, is offering family members the chance to see a loved one over FaceTime or similar technology. And so and I'm not the only one to do this. We do this this is being done at many, many hospitals, most likely. We have donated iPads, and we stick one in a biohazard bag, and we bring it into the room so that even if the patient is intubated and sedated and not clearly aware of surroundings, the family is able to see the machines. They're able to see the lines, the tubes. I feel, based on family members' responses, that helps. That helps to give a picture of the reality. It helps for them to be able to say to their loved one, in whatever kind of way they say it, "I love you." And it allows a bit of connection, that visual connection that wouldn't exist otherwise. So I think that is something that has, using technology as we all are in our daily lives to try to maintain connection in the setting of social distancing, that has helped in the hospital as well.
What has your experience been like working in an ICU recently? Take us inside a COVID-19 ICU.
So I can give you a view into one, say, recent night shift. We do stretches of about 12, which ends up being 13 or so hours at a block. And you enter the COVID ICU. And so in our hospital, we have essentially cohorted all of the COVID patients, the ones who need ICUs and the ones who don't need ICUs. We have a building that used to be dedicated to our cardiology patients, and they've all been moved. And the reason that we have all our COVID ICU patients in this building is that each room is a single room, and each room has the ability to be a negative pressure room. So the airflow in the room can work such that the air in the room doesn't leave the room. And so this is the kind of room that is safest to have a patient with a respiratory virus like COVID. So we have built now about 6 different ICU teams that are dedicated solely to taking care of COVID ICU patients. So that's more than 100 COVID ICU patients, many of whom are sick enough, most of whom really are sick enough to be intubated. And so, for whatever reason, our teams are all named with colors. They're actually crayon colors. The head of the ICU, I think, was looking at a box of crayons. And so all our teams are named with colors. And so on a recent night, I was on the green team. I was on the orange team a different time. And it feels like kind of the strangest summer camp ever with these colors. And you walk into the unit, and what strikes you first, in contrast to a regular unit, I think what struck me first, at least, are the ventilators. And so in general, in an ICU, the ventilators sit next to the patient inside the room. In the COVID ICUs, in a sort of handy way, we, along with many hospitals, and this was something that I had actually first seen on Twitter, I think, before I saw people in my own hospital do it, separate the monitor of the ventilator from the body of the ventilator. So the monitor, attached with an extension cord, snakes its way out of the patient's door. And so each patient's room has a ventilator monitor on a stand outside the door. So you just see this line of ventilator monitors that strike me a little bit like disembodied heads. And you can walk by and you can see how the patient is doing on the ventilator without even entering the room. And of course, that's handy, right? Like it saves us PPE, it saves us exposures, but it also quite literally disincentivizes us from entering the patient's room. And it is so easy to end up knowing these patients specifically by their monitors. Oh, this is the patient who's on an FiO2 of 60. This is the patient who's on a PEEP of 12 ventilator settings. When I was looking at it for the first time, a resident walked by and he saw me sort of marveling over these monitors and the way they were out of the room. And he said, it's like a little like a video game, isn't it? And it's true. Peering inside the rooms, it's different too. Many of our patients, we're not used to having so many patients intubated and deeply sedated in an ICU. Yes, we have intubated patients, but we also have patients who are awake, who are sick for other reasons, who need an ICU but are able to communicate. But here, patient after patient, you look in the room and they're intubated and they're often lying on their stomachs rather than their backs, something called prone positioning, which we've known for years, since a large study proving this improves mortality in severe respiratory failure. And so we've done it on occasion, but in patients with COVID, for reasons that we still do not fully understand, it's even more effective. We even do it for patients who don't need intubation yet, who are on nasal cannula. They get better when they lay on their bellies. So we have these line of patients, ventilator heads outside the room, line of patients often laying on their bellies. You can only see the back and the side of their heads. And as we were saying before, there's no family. We're used to seeing a loved one, at least one loved one, sometimes more, at every bedside. Here, there's no one. The patients are often alone inside the rooms. And of course, everybody is wearing their personal protective equipment. And so it is odd. It's a very odd and both busy and quieter than the ICUs that I'm used to. It's an active ICU. I mean, patients get sick, patients desaturate, they need quick ventilator changes, patients go into shock, they need lines placed, patients need to have renal failure, they need to be started on dialysis, renal replacement therapy. There's a lot of movement. And then there are the calls to families. There are the iPad visits into the room. And then there are, on occasion, extubations, which are things we are seeing more and which are obviously a cause for celebration each time.
So there are a couple of phrases you use there, and they become somewhat common as we have all become, unfortunately, a little more accustomed to getting some insight from inside an ICU. But I'd love you to explain them: intubation, excavation, and honestly, what is it like to be on a ventilator? Or I shouldn't say what is it like, but what is it like to be put on a ventilator? Could you explain a little bit more about sort of the details behind those words that we have become, again, a little more accustomed to hearing, but maybe not having had them explained to us?
So, intubation is the process of putting the breathing tube down somebody's throat and into their trachea to be able to connect them to a ventilator. And the way that generally works is that when somebody is on so much supplemental oxygen, so much extra oxygen that the nose prong oxygen is not enough, we begin to think, or somebody is struggling to maintain an adequate oxygen saturation, even with the extra oxygen that we can give them, we talk about putting them on a ventilator. And the ventilator itself is not a treatment for lung disease. It really is a way to deliver enough oxygen so that the lungs ideally have time to heal from the damage that was caused. So it doesn't improve the lungs to put them on a ventilator. It just allows us to buy time to heal. Ideally, if there are targeted treatments that allow things to improve, the ventilator lets us buy time. And so when we talk about putting somebody on a ventilator, the process of getting somebody on a ventilator begins with intubating them. And so in our hospital, the anesthesiologists are the doctors who intubate. And we call them. And ideally, if there's a little bit of time, if the patient is not so sick that they need to be intubated that second, we try to give a patient a moment to talk to the family. It's something that we've tried to do even before COVID, when families aren't around, or when they are around, we bring them into the room and we say, we hope that you're able to come off the ventilator. The goal of putting down this tube down your throat and connecting you to a ventilator is to get you better. But there's always a chance that you don't come off. And so if there are things that you would regret not saying to people you love, let's give you the chance to say them now. And that's hard, but that's something that we do. In our emergency department, where intubations happen often with even more urgency, a colleague of mine has taken to, when he can't get a patient's family member on the phone, he's actually taken to asking the patient if he or she wants to record a message. And so he takes his own iPhone and he has the patient record either an audio or a video message, whatever the patient prefers. And he sends that to the family later whenever he can get in touch with them, because there's a chance that it's the last time that they get to say something to somebody. That being put to sleep is a sedative medication, propofol. Sometimes it also comes with a short-acting paralytic, a medicine to paralyze the muscles so that it's easy to get the tube in. We make sure that somebody is deeply sedated, so it's not as though their muscles are paralyzed and they're awake. And then we slide the tube in, connect the tube that goes down the throat, down the trachea, connect it to the ventilator, and then set the ventilator settings to give the patient oxygen enough to keep their body safe, but also while being careful with the settings to not do more damage to the lungs by giving them sort of high ventilator settings that they might not necessarily need. So that's a delicate, and that shifts over the course of minutes to hours to days. When somebody then is getting better to the extent that they no longer, and so I should say actually, while somebody's intubated, often when they're sick enough to need sort of significant help from the ventilator, they're deeply sedated. That's for two reasons. One is that some amount of pain control med and sedation is often needed just to tolerate the discomfort of a tube down the throat, causes gagging, discomfort. Beyond that, the ventilator itself delivers oxygen and breaths, and the way we set that ventilator sometimes is not physiologically comfortable. So the breaths we give a patient are a different size and different rate than what you and I would do if we were just allowed to breathe. And so it's important for the patient to not fight against those settings, because these ventilator settings are made such that they get enough oxygen without causing inflammation and damage to the lungs. So we make sure that a patient is sedated enough that they are in sync, we say synchronous with the ventilator settings. And so that's sort of the reason that somebody goes into what is often called in lay parlance, a medical coma, is to be sedated enough and get pain control enough to both not be in pain and gagging from the tube, and then also to be on these sort of hefty ventilator settings that are not necessarily comfortable. As somebody improves, as their ventilator requirements decrease, we change the settings on the ventilator to actually simulate somebody breathing on their own. And in this setting, they're often comfortable enough so that we can lighten sedation. They begin to wake up, do things like squeezing our hands to command, sticking out their tongue, wiggling their toes, are with it. And once they're with it enough and can show us on the ventilator that they can breathe on their own, because we simulate that with the ventilator settings, then we can take out the tube, and that's called extubation.
So ICU is a harrowing experience, and especially from what you're describing, to be intubated for a patient. I'd imagine it could leave a patient with scars and a family with scars. What does it mean for a patient to experience post-ICU syndrome?
So post-ICU syndrome is a term that we've now given, as of 2010 or so, we've given this constellation of problems that can begin after the ICU and sort of last and persist. And, historically, ICU outcomes were measured sort of simply in mortality. Was somebody alive or dead, or in time in the ICU or time on the ventilator? But critical care researchers have become more interested, and doctors and just humans, in what actually is the quality of life of those whose lives are saved by intensive interventions. And as we started to look at that, we came to understand that in ICU survivors, largely those who are sick enough to need a ventilator for a couple of days, so many of these patients with coronavirus, they come to suffer what's called post-intensive care syndrome, which is defined by anxiety, depression, post-traumatic stress and symptoms, cognitive dysfunction sometimes that manifests as forgetfulness or difficulty making decisions, and physical issues after the ICU. And depending on which kind of parameter you're looking at and what study you're looking at, the numbers are different, but something like 1 in 3 people who are sick enough to need a ventilator will have at least one of these issues afterwards in ICU survivors largely. We haven't studied the COVID survivor population yet, but it stands to reason these are people who have had sometimes long times on ventilators and also have had this really persistent isolation. And so with that, I think, largely we suspect that many of these ICU survivors will face these new challenges even after they get healthy enough to leave the ICU.
Doctor, you've given us a great insight and perspective on what's going on with your patients, which I know is your number one priority. But I think we all do wonder how all of this is affecting our doctors and nurses. So, if I could turn the lens back onto you, how has this affected you, not just as a doctor, but as a person?
The ICU that I'm used to working in, so pre-COVID, I'm at Brigham and Women's, and so we're affiliated with Dana-Farber Cancer Institute, and so which is not an inpatient facility. So we're the inpatient hospital for Dana-Farber, which I say to explain that I'm used to taking care of really sick patients and seeing a lot of death in our ICU. 2 weeks before our first COVID patient I was on in our ICU, and we had 4 patients pass away over 24 hours. And that was a really tough 24 hours. My residents were exhausted by it. I was exhausted by it, emotionally exhausted, and also just sort of physically exhausted by the idea of, going back and forth between patients and communicating what was going on with families. So we're used to that in a way, and you don't really get used to it. I'm just used to the feeling of being sort of deeply sad and spent by the ICU. I think the thing that's different now, there's a couple of things that are different now for us, and it's the fear, which fades over time, but then kind of flares. But I remember the first COVID ICU patient that I had, I was really scared to enter her room. And like that is a very foreign feeling. And I had PPE. Like it wasn't that I wasn't going in protected, and I obviously had to go in, but this sort of fear of entering a patient's room is something that makes you feel guilty for feeling that, and it adds this like significant layer of fairly exhausting tension over the day that it's just foreign to us. I mean, I've never worked in a context where I am legitimately worried about getting something that somebody has that could hurt me. I haven't been, most of my patients are really sick, but I don't worry that that is going to impact my life in terms of my health. And so that's different. That is a different level of tension. I also feel like it's hard to be the kind of doctor that you want to be when there's a lot of patients. You have this desire not to enter the rooms, even though you know you have to. You don't ever meet the families, which means in a way that you don't really meet the people, the patients themselves, because when they're so sick that, you meet them intubated, the breathing tube in, sedated, you meet them through their families. And so it is hard to feel like you are practicing medicine the way you want to practice it. At the same time, there is this real passion for being in the hospital and for being a doctor, or which is true for all sorts of healthcare workers too, right now. I mean, the disease is horrifying, but it's also fascinating. I mean, we are in this period of time where we are learning about something new as we are taking care of patients with it. I've never had that experience before, and I don't think that I will again. And there's this real collegiality and camaraderie. Perhaps it's because we all have this shared fear, but we're all also taking care of these patients in the middle of a pandemic that is in this, our broader sort of nation and world. And that sort of singularity of focus and camaraderie has made many of the sort of smaller annoyances of medicine seem like temporarily they cease to exist because our purpose is so clear. And so there's fear and there's sadness, but there is also this idea that like we are all mobilized to do this together. And I think that there's a great kind of, pleasure isn't the right word, but those of us in the hospital right now feel honored to be there, I guess.
So another question that sort of is on the personal side before I pull the lens back and ask you some big picture questions. And that is there a case, maybe an image, maybe a moment with your fellow healthcare workers or a patient that you expect to stay with you long after this has ended?
Yeah, there are many moments likely so far, and I'm sure there will be many more that I expect to stay with me. I'll give you two kind of contrasting. One moment is standing in full PPE garb at a patient's bedside while I'm holding an iPad through which his daughter, his adult daughter, who's in pajamas, is seeing him for what will be the last time and saying goodbye to him in sports metaphors. And I am trying to hold the iPad still so that her last image of her dad is not jiggling by my hand, and kind of peering in to make sure she's getting like a good view on the screen. And having her say things to me like, "Hey, can you just go a little to the left, a little to the right?" So this like combination of the kind of mundane, like get a better view on this iPad, and utterly profound, like a saying goodbye to a loved one. And that feeling, and trying to hold my hand steady, and that feeling will stay with me. Another, just from the other day, this was from like a couple days ago, but I saw a patient. So I've been doing some rotations as well in this post acute care, so sort of recovery from COVID area. And I saw this patient yesterday who I had taken care of, who was my first COVID patient nearly a month ago now, intubated for weeks. I had, worked with the nurses to turn her over when she was so sick that she wasn't oxygenating well on her back. We needed to turn her to her belly. I knew her in that way, which was intimate, but I didn't know her at all. And was shocked when she was extubated, when we got the tube out. But she'd been so deeply sedated for a long time. She was delirious, very confused. So I worried that she would have some, significant sort of cognitive issues from her intubation, her long intubation and sedation. And she was, relatively young, active, academic beforehand. Anyway, I saw her yesterday, and she was like totally normal, having this long conversation on the phone that I had to interrupt to talk to her. She's very weak, so she's still walking with a walker, but she will be able to walk on her own. And so this shock and like great pleasure at talking to this person who I felt like I knew so well in some way, but didn't know at all, will also stay with me. And that's not to say that, to talk about post-intensive care syndrome, that just on this like one conversation when I told her, "Oh my God, you look so great," I'm sure that she will face things that she wouldn't have otherwise. And I hope that we can get her plugged into, the appropriate specialists to make sure that she kind of can thrive after surviving this. But in that moment of seeing her be okay, and of knowing that she could have died, but she didn't. And the things that we did for her were the right things, or at least were okay things, allowed her to get better. That made me feel quite good. And I'm really glad that I got to see that, because there's a lot of death and sadness that's associated with COVID, but there is also survival and there's also success. And so that will stay with me.
When you pull the lens back, and I wonder sometimes if you can even do that because what you're dealing with very much up close takes a lot of time and energy. But if you can pull the lens back, how would you rate our response to the virus outbreak? Preparedness, treatment, things along those lines.
I think if I could pull the lens back and sort of think about how this all has unfolded, And we were clearly behind. Clearly, we're not prepared for this in any way, not in terms of testing, not in terms of making sure that our hospitals were ready by having enough personal protective equipment for their employees, by having enough ventilators, by having enough dialysis machines. And so I think we were behind. I think with that, we have done our very best to catch up, so to speak, but I think we've been operating at a deficit. I mean, there are protocols that we've developed on the fly that ideally could have been developed in a more thoughtful way ahead of time had we taken seriously the fact that this was going to become a pandemic and that this was going to get us. I mean, even still, we're not prepared. Like, we're talking about reopening, and we don't yet have a robust system of widespread testing, tracing contacts, isolating people once they're found to be COVID positive. And so I think that there will be, great saves that are part of this story. There will also be a tragedy of slow response and the tragedy of isolated deaths.
We here in New York, where I am, we've seen within the big numbers, the statistics, some improvements, some places where we feel hopeful. A number of hospitalizations and deaths are going down, but the numbers were so big before they were daunting and frightening, quite frankly. So I'm wondering, in your hospital, are you seeing some of those same trends in the numbers? Are you seeing, quite frankly, a light at the end of the tunnel?
I think we're all looking toward New York to sort of as the barometer of how this is going to go and how it'll be okay. We're behind you guys in Massachusetts. We're behind New York, and also our slope has never been nearly as steep as yours, as you know. So we're still on an inclining slope, but I think that knowing that an apex does get reached and then things get better, I think we do see a light at the end of the tunnel. I'm still not sure what it'll look like. Like, I'm not sure, do we continue to have COVID ICUs? Will we always have COVID patients? Will they be with other patients? How is this going to unfold? I can't really imagine that. I don't really know yet. But I suspect, we see our numbers continuing to increase, but not at as high a rate. And so I do see that this will come to a close, or at least the surge part will. I'm not sure how long the after will linger. That's kind of a question that I have. I don't quite know how that will look in 4 weeks from now.
Let's talk about maybe the way after, if you can. Again, if you can get your head into that place. But what does the world look like from a medical perspective after an outbreak? Do you see substantive changes, long-term changes that could come about because of things that we learned and maybe we learned the hard way from the pandemic?
I hope that the world will look different after an outbreak. I know there's also a kind of human reaction just to kind of go back to status quo and say, all right, well, that happened. That was weird. Hopefully, it won't happen again. But my hope is that in a bigger picture way, we will be have a more robust system and a robust system ready to test if something like this ever happens again. I think that the world is going to be different, or at least our worlds are going to be different for a long time, perhaps forever. I mean, I think that we now understand in a way that we did not before the extent to which contagion spreads between us and the fragility, really, of this sense of safety that we've all had. The kind of precarious nature of kind of all of these things that we have build and then can just disappear in the setting of a pandemic. Oh, you don't go to restaurants anymore. Okay. In the hospital, I think that infection control precautions, I think that things like wearing PPE, I think that things like wearing masks will probably be protocol for a very long time and should probably, potentially for the foreseeable future at least. And I think that's a good thing. People can only keep up fear for so long. I think, there's a sort of fight or flight initial response, right? And then adrenaline kind of fades and you become tired. And so I don't think that we can keep up the fear forever, but I think that we can keep up some of the protocols that we've started of being more careful, of making sure that, doctors and healthcare workers wear masks in the hospital, making sure that hand hygiene, which we've known for centuries now, that ritualized and protocolized, not just for surgeons. So some things will change, to be sure. I look forward to having families back in the hospital. I'm not sure when that can happen, but I think it's going to be a slow and stepwise progression. I think it's foolish to think, and nobody really thinks that coronavirus will be gone when this sort of apex is over. I think there will be cases again. It's just the test of whether or not we've learned from this is whether, when there are cases again, we are able to test them quickly, we're able to trace contacts, we're able to isolate them, and we're able to stop another spread from happening.
So my last question to you, mentioned, you can't keep up the fear forever. Well, there are people in this country who are already pushing back, questioning the severity of the virus, flouting the social distancing practices, questioning the advice of the medical community, protesting, quite frankly, against what has been put in place ostensibly to keep them safe. Is there a message that you could give to those people? What would you say to people who are questioning what you're going through to a certain degree?
To people who are questioning what we're going through, what we see every day, I mean, I would say first, I get it. Like, I get the fact that if you are walking down the street or at home and you feel fine, you wonder, why does life have to stop? If you're a small business owner and your business is destroyed, I mean, I completely, I don't know what it feels like to be there, but I can imagine feeling like this is too much. At the same time, we look at these sort of contact tracing maps. We look at the way sort of people have a family gathering, they see another person, and death spreads. And it is really only by us all buying in, by us all saying, okay, like, we're going to do this thing, and we're going to do it because it's our responsibility to everybody else. It's only by that we get out of this thing. People are talking about, like, doctors as heroes. I don't know about that. I mean, we're going to work doing the same thing that we've been doing. I think that everybody has to have a bit of this, like, heroism, to whatever extent that's defined as doing something that is uncomfortable. And they do that by staying home, by not doing the things that they want to do. And because it's really only by doing that we are going to emerge from this, and that lives are being saved. It's harder to see that you're saving lives if you're at home and watching television and furious that you can't rejoin your life, but you are.
Dr. Daniela Lamas is a pulmonary and critical care doctor at Brigham and Women's Hospital in Boston. Dr. Lamas, thank you so much for your insight. Please, to you and the rest of the people you work with, stay healthy and stay safe.
Thank you so much for the opportunity. It was really a pleasure to speak with you. So thank you.
At apnews.com, today's One Good Thing feature is a story about a birthday party. Drive-by birthday parties have replaced the typical backyard or bounce house gatherings of children during this time of social distancing. In Arlington, Virginia, Josiah Lee's 6-year-old celebration turned into a parade with a fire truck, police cruisers, and dozens of families in cars decorated with balloons. The parade was organized on social media by Ashley Johnson, an accountant who met Josiah while volunteering at a homeless shelter in Washington, D.C. 4 years ago. Read that story and all of AP's coronavirus outbreak coverage at apnews.com.
That's it for this episode of Ground Game. We'll be here every step of the way during this extraordinary moment in American politics and American life, giving you all the news you need to know. Be sure to tell a friend about us, and please subscribe on Apple Podcasts and leave us a review. Some of the details of our discussion may have changed by the time you hear this. For up-to-date developments on all of your news, head over to apnews.com. From the Westwood One Podcast Network.